Risk management is so important. You see this room just full. Thank you for, again, sticking it out here. Today we're going to talk about risk management updates. So our agenda will be the CARES Act, which ended May 11th. We'll go through some changes to the No Surprise Act, some coding changes that we're seeing, new laws on human resource. We're going to talk about HIPAA and privacy, security, and cybersecurity being the hottest topic. Some couple of things that we're seeing in malpractice that are really helping, and then also some new changes to physician anti-kickback Stark that affects your compensation and investments. So as you may know, that the public health emergency ended May 11th. And that really would affect a lot of COVID testing and all of those types of incentives or free care that we've been getting through the government, but also it is affecting telemedicine, okay? So telemedicine they started trying to, the federal government in 2014 really tried to incentivize primary care to get telehealth out there, telemedicine, whatever you want to call it. It's both similar, but they tried to get it out into the systems. They took it into Texas. I was able to have the opportunity to help the Epilepsy Foundation of Texas link the primary care with the specialists in Dallas, Houston, etc., and through telecommunication. Now, the specialists and neurologists that treated epilepsy patients were a little skeptic. They're like, "Hey, I have to touch and feel and test," and the patient, in the beginning, maybe this will be good for medicine management. So they test piloted it, and it didn't take off as well as the feds would have liked it. And I think, physicians and specialists were trying to get used to how to, communicate to patients online, and the equipment and the reimbursement really wasn't there either. So when the pandemic hit, we noticed that I think from March 1 of 2020 to February 28, 2021. So in 1 year, we had 742,000 providers doing telemedicine through COVID, which was unprecedented. So, COVID changed how we kind of interacted with the patient. About 88% of the beneficiaries, Medicare beneficiaries, had at least one telehealth service. In the first year of the pandemic, we had more than 2 out of 5 beneficiaries use telehealth services for the first time ever. Medicare and private insurance started coming along, and we did see certain groups like telehealth and telemedicine a little bit better than other and mostly underserved groups. So we did see that dramatic increase in telehealth services. I am seeing CMS in the last 2 years take reimbursement down on telehealth services. Now, at first, through the pandemic, we were reimbursed at an office visit rate, and now they're starting to put you back on the telehealth medicines or telehealth codes. So you will need to start doing the other codes. There are 3 new codes that are out, and we'll go through those. Oh, Medicare said because of the high influence, we also had a huge amount of fraud and abuse. There was a total of 16 100 providers under indictment as of yesterday. So these new codes, there was 3 new codes that came out January 3rd, 2023. And the first 3 are for one per E&M family. G0316 is for prolonged hospital inpatient observation services. Now, don't get that confused with your critical care. Your critical care codes are still out there, which is the 99292. Those are 30-minute increments, so don't forget those. The other new one is G0317. It's prolonged nursing facility services. And the last one is G0318 for prolonged home and residential services. So those are the 3 new telemedicine code changes. I talked to, on the chronic, I talked to CMS and I said to him, I said, well, why do you keep making these G codes when the AMA is the ruler of CPT codes? And they said the AMA is not keeping up, in their words, the AMA is not keeping up with a lot of the codes that they need and services, that they want to designate payment for. And so that's why we're seeing the G codes, because as a healthcare consultant and all these different codes and new ones coming up, it gets a little crazy. So that's what they said. I thought that was very interesting. The 2 new codes for chronic care are G3002 and G3003. There's also a new telehealth code, telemedicine code for behavioral health for psychologists and clinical social workers, which is the G0323. Now remember, all these new codes that came out are for Medicare beneficiaries and then your Med Advantage plans. They will continue to, you will be able to continue to bill the place of service, office visit, and you must use the modifier 95 through the end of the year, okay? Now, they are going to cover telehealth, and they're going to be pretty flexible on the applications that we're using. So the cell phones at the end of December will be non-existent. We will have to use more secured telehealth platforms. So that will be coming. There will be a lot more restrictions. So most of these codes still you can, call the patient, discuss information with them, or do a FaceTime and still qualify till the end of the year. After that, you will have to have a more secure platform. So they have extended it, and that's why we have the 151-day extension to give you more flexibility. And also geographically on sites, they're allowing us, pretty much they allowed us to any geographical location in an originating site setting, because most of our providers were at home and, speaking to the patient at their home, not going into their medical office and providing, services to the patient's home, et cetera. So they are, we will see a lot more restrictions on that, but not until the end of the year. So there's more information coming. They still are allowing certain services to be provided, audio only, for, chronic patients at home. So be really aware of which ones those are. And also they still are allowing the PT, OT, and speech, language, and pathology, audiology to do telehealth services. Now, we did get information about also the federal qualified health clinics and the rural health clinics. When the pandemic first came out, they were not allowed to do telemedicine. And that was a real detriment for a lot of the rural areas. And we kept pushing and pushing and pushing. And finally, I think it was about 6 months or maybe maybe 3.5, 4 months into the pandemic, they finally started allowing them to provide telehealth services, which was a great win. They will still keep that. So that's a good win. The other change we're seeing with the telemedicine is the DEA and the prescribing. Now, they too are giving us 6 months. They're giving us flexibility to prescribe controlled medication to the patients till the end of December. After that, we're going to they're going to go back to and reinstate the restrictions where you can only, Schedule 2 will be required in person. Schedule 3 or higher can be prescribed for 30 days via telehealth or required in person before refilling. If a patient is referred to a provider, inpatient visit is not required if the patient saw the referring physician in person. So there is some leeways there, but that was the very first part of the law anyway. So, and then they had to open it up to everything during the pandemic. So we will see those changes coming at the end of the year as well, those restrictions. The No Surprises Act. So that was the CARES Act, the No Surprise Act. How many are familiar with the No Surprise Act? Okay. How many provide ER services to the hospitals? Okay, you're on call? Okay. Well, it really affected a lot of providers that were on call. And as we know in the healthcare market, insurance plans are not always very generous with the plans that we're able to see within, their company. So say, for instance, you could have, say with Molina, you could have the traditional Molina, but you don't have the marketplace. You didn't get the new contract, and they didn't give you the marketplace. You could have Select Health, and they give you choice and care, but you don't have Med and Value and Individual Family and all these other plans. So when you go in to take care of a patient in the ER, you don't have that plan. You're in an in-network facility, right? But you don't have the plan. So you're an out-of-network provider. So then these patients are going to be getting a surprise bill from you and the anesthesia and the radiologist because they were not on you're not on the plan. You were not allowed to. Even though we have in Utah, in 2018, we did get on the docket any willing provider. So any willing provider says if we sign a contract, if we're willing to sign your contract, then, they could give us, access to the insurance company and their managed care. But that doesn't mean that they have to give us all the plans. And that's a big problem with with providers on call. We're dealing with that a ton. Patients now have a right to price. Have you heard of price transparency? So patients want to know how much, especially if they have a larger deductible, how much they owe. So there's two things kind of coming at us. And so, the Surprise Act protects the patient from surprise medical billing and establishes a resolution or dispute resolution for pricing. Now, if you saw a patient in the ER and you submitted the bill and they denied because you're not on that plan, then, you're working for free, right? Well, the great thing about it is in the state of Utah, there is a 90-day law where the hospitals have to cover your services in the ER and any service after that for up to 90 days. So that was a big win for our providers because, you know, a lot of providers, the trauma docs, the cardiology, the GI, if they were independent groups and they didn't have all the plans, you know, they were struggling to get paid. And so that was a big, big win. Now, yes.
So with that 90 days, then that is the length of time from the visit where the provider is covered, or that is, so is there a cutoff from, say, the provider doesn't realize he's gone, or hasn't gone through, and it's a year out? So we're talking about the coverage time period where the provider is in the ER?
So the provider sees the patient in the
Could you repeat that question? Is it basically what is the 90-day period referring to?
Yeah, the 90-day period is referring to when the provider sees the patient in the ER and they bill the service, right? Anything between the time they saw that patient for 90 days, the insurance company, whether you're in network or well, out of network, they have to pay in network rates. So, and the big stickler of this is that when you see somebody in the ER and you have to admit them. So now it's an inpatient code and we're not billing an ER code, right, for, you know, the consult. Now we're billing an inpatient code because we had to admit them. So you need to keep your records. Feel free to contact me. I have the law. I also have clips from every payer that guarantee that you will be paid for the services, while you're on call for up to those 90 days.
Does that come out of the pocket of the hospital or the insurance?
The insurance companies, yeah. It's, the hospital, let's put IHC out there, right? IHC, we have this hospital, we have, let's say we have orthopedics that are independent, but Select Health didn't give them, all of the plans, which we see a lot. So they don't have all the plans, but they're covering the ER for trauma, for ortho. And so then we have a problem of where, we couldn't get on the network, for these plans, and these patients are coming through the ERs. The other one was we had some anesthesiologists in a couple of states that refused to sign contracts with a couple of payers because they just could not settle on a negotiation. And so they were out of network, all of them. And so in some states, well, most of the states, this law kind of kicked in, 90 days you have to pay. Because the disputes, tactics that the federal government put in for the doctor and the insurance company to dispute the payment is cumbersome. And
IHC has their own insurance product versus a lot of other hospitals don't. So there's like, if someone went to Ogden Medical Center and they didn't have, let's say you weren't on a panel for Blue Cross Blue Shield for some reason, then who would pay it in that case?
they would, if you're doing ER call and you're not on a panel or a plan, the hospital hopefully is paying the provider for call, right? Hopefully the hospital is paying our providers for call for the time that they, can't go to the movie with their family or, can't go out and have a glass of wine. But on the same token, if they are in the ERs, then the state of Utah says, we don't care what plan you have, what entity you are, insurance company, you will pay the providers the in-network rate. And that includes also when we're inpatient. So if we transferred them inpatient, we don't have a now place of service ER. We have an inpatient place of service and an inpatient code. Those two will be paid, and up to 90 days. And that means that, okay, you saw the patient, you put them, inpatient. They had to, kind of get a little bit more settled. then you take them into surgery that next day, that too will be covered. So don't let the insurance companies try to deny all your stuff because they have to cover it, which was a good win for the providers and getting those paid.
But this is only for emergencies.
This is only for emergency. Yeah.
It's only in Utah.
Utah is one of them. There's a couple more that have similar laws. It was a good win for Utah because we have such games here. So that was a really good win. They have, the CARES Act. We are, the No Surprise Act and the CARES Act kind of in tandem came out because of patients. And patients wanted to know, what their rates were, and they wanted to pay. I have several clinics where, in fact, I had one healthcare attorney call me and say, Jackie, could you just help this clinic? I have a $12,000, high deductible. I want to pay, my bill when I'm there. Can you help them? They don't know what to charge me. And so that is becoming more and more. And as you know, in self-pay, we do need to give them an invoice or a cost estimate, all self-pay, and that is part of the act.
Question, is there a standardized, national level of what somebody can charge for somebody, for a service? I know that different companies and different, entities have different rates. Is there like a national average or something?
Is there a standardized charge out there for physicians? Well, we all hear about usual and customary, right? Well, I've defended it in court, and there's no such thing, okay? I do speeches across the country about how, how do you create your gross charge, and how to maximize your revenue. There isn't. And so IngenX tried to create gross charges, and they still put out their books, right? That was 3 ladies in New York at a bar that wrote down CPT codes and gross charge, and I'm not kidding, and started publishing it, okay? 8 years later, they were sued by the federal government because they had no method. And so IngenX has slowly kind of changed that, but they were in trouble. A lot of providers say, well, we do a percent of Medicare. Well, that doesn't work either. The best thing that I have seen to actually figure out what to charge is what are the reimbursements of all my payers, and set it a percentage above that, with the caveat of what does it cost us to provide the service? Because I can't charge, $200 when it costs me $325. So there's a fine line there.
Well, now that, people are doctor shopping, not in a negative way, but, for services, they go to different places, and different places all have different prices, and with transparency, you need to throw out a price for getting my tonsils out, or getting tubes in my kids' ears, and I don't know where to get all that stuff.
Well, remember, there is a law out there with Medicare that you are not supposed to be below Medicare if you're a Medicare provider, right? And so we see a lot of that, especially in X-ray. They say, oh, if you want an MRI, you can come in for $299. Well, that's great, but is $299 going to be, below Medicare? And typically it is for with contrast and without, if we're doing a MRI with and without contrast. So, yeah, you have providers out there that put kind of smaller amounts out there, like $69, for your visit, and most of the time we find that some of them are really not compliant. And some of them, have changed their, practice. I think I have 3 clients that called in the last 3 months. They are tired of managed care. They want to go direct primary care and get rid of insurance altogether. They want to see the patients the way they want to see the patients. They want to treat the patients the way they want to treat them. They don't want to be, filling out this and checking that box and, doing a lot of things that they feel is not really helpful to them for a cash amount. And it's like, okay, well then, I want to charge 65. Well, will that cover your overhead and pay the bills and keep the lights on and pay your staff? Or does it have to be 85? What is it? So there is no rhyme or reason out there. I've been an advocate trying to change that because there is methods out there that really work and that maximize, revenue and then make sure that you can keep your doors open and viable. So there is no standard.
If you don't accept any insurance, you can't set your own prices?
Oh, you can.
But are you in about?
If you're a Medicare provider, you cannot set your own prices
So only if you
below
don't-
Medicare.
Yeah, okay, so I
Yeah. If you do not take Medicare, then you can set your, yeah.
do you have,
And Medicaid, state.
there are a lot of charities like United Healthcare who I've just so enjoyed, who will undercut Medicare rates.
Yes, there are payers that undercut Medicare rates, and we should not allow that because most of my primary care, when we actually figure out how much it costs to keep the doors open and, the NPs paid and 2 MAs and receptionists, we're about 125% of Medicare. So, yeah. Okay, so on the No Surprise Act, there is going to be a new ABN. Now, it comes effective 6/30 of 2023, and the current ABN, if you continue to use that after June, it will not be in effect. In other words, the patient could actually tell you, you didn't sign the right form if they actually knew. But there is a new form out there, and it should last until at least 2026. Usually the ABNs are updated every 3 years, but the new one comes out June 30th. So you'll want to, be aware of that. And it affects, all the providers, practitioners, suppliers of Part B, and then the hospice providers, and then also the health agencies. Just want to see there.
This only applies to Medicare, right? I'm just curious, how does this work? Is this now like getting a mortgage? Your surgeon tells you that you need to have your gallbladder out, they send you down to billing, and they hand you a packet of pills and say, sign these?
Well, the ABN, there is not a lot truly that Medicare doesn't cover. If you pulled down the Medicare fee schedule and looked at, other payers, they're pretty comprehensive. But there is a few things, that you may do that Medicare doesn't reimburse for. Honestly, I like to create a generic one, advance notice to all patients. So like my derms, Cigna only covers 3 moles to be removed, and then the rest are cosmetic, right? But United Healthcare will pay for 6. So how does a clinician, determine all of this craziness in the exam room when the patient's like, well, does this one look, kind of different? You get so distracted that, doing a generic, say for derm, your insurance coverage may not include all of the services today, including additional, lesion removal or mole removal, and they sign that. It's the same as an ABN, but you know what services you provide. look through, and if there's any that Medicare does not, honor or pay for, then, issue that to all those patients that come through.
That's kind of hard too. That's like a no surprise act, because then your patient gets a big fat bill of what wasn't covered. And then is our hands bound that we can't give them a discounted rate because they have to pay cash for it now? Or do we have to still charge them the regular rate that we charge every other person who has insurance?
Well, on the provider side, to give a discount rate, there are standards. So typically in the, we try to give the practices standards to go by, and that's poverty level. So there is a poverty level thing that says, okay, if the family makes this much, you can give them 20% discount, or a 30%, or a 50 or 60, 70% discount. So we try to use that as the standard because it's a federal criteria, and that's helpful. If you would have noticed that, do you remember going into the hospitals 2 years ago and they're like, if you pay your deductible today, I'll give you 20% off? You remember that? Now it's not quite 20%, and you're like, well, how did they do that? I mean, because that's a pretty big discount. Well, the insurance companies can't dictate how your financial policy works, okay? They can dictate that you collect your copay, your deductible, and your coinsurance. But if they can't pay the bill altogether, then, let's set some standards. But the hospitals looked at their bad debt and said, our bad debt is 15% of our income. People are not paying, and we're having to send them to collections. We never get paid. So they said, okay, to curb that, let's give them that discount. Let's try it. Let's see if it worked. And it worked. It worked. So the insurance companies are going, now wait a minute, how you can't, you're supposed to collect all of it. And they said, well, you can't dictate our financial policies, and our bad debt is X. So we can justify that. They have ratcheted it down. I know that HCA now does 10%. It was 20% if you paid that amount today. Now, you still had to pay whatever residual, if they didn't get right to the penny, but which we have on all of our patient estimators, too, in the clinics. So, new ABN, that's coming out June 30th. So, on the No Surprise Act, a lot of providers were not aware that you have to put a link to the No Surprise Act on your website. Many bigger clinics actually put the whole 2 pages on. You didn't need to do that. You just had to do the link. Now in the clinic, you do have to post the 2-page notice of the No Surprise Act, and we typically put it right next to our HIPAA policies. So provide a patient estimate. I mean, we all know, I have clinics that say, well, Jackie, how am I going to do that? Because by the time that patient is done, not all my chart notes and everything is complete, and I have 3 patients waiting. Well, maybe super bills are back for a bit for those self-pay patients, so that they can take it up. I can tell you exactly what you're going to get paid from all your payers, and with the CPT codes, we can collect that money today. Collaborating with the payers in the ER, that was another thing that came out of the No Surprise, and again, the Utah law was a huge win for our doctors, because that would have been devastating, especially with the 90 days. and make sure you secure your ABN. Now, coding compliance. Coding compliance, there are several, different things. Coding compliance refers to diagnosis and procedure coding that complies with all coding laws and guidelines and regulations, right? And so we try to follow Medicare, and then that changes, and E&M's changed. We have a little bit of time factor in there now, not all medical, history and services. I'm not a certified coder, don't claim to be, but I have seen huge increases in denials from payers this year, okay? And they've changed softwares, and they're really focusing on ICD-10s. So it's critical that we, look at your diagnoses. It's also critical when we don't comply. It's critical reimbursement, and you get overpayments and underpayments going. It prevents fraud, of course. It improves the patient's care, and also it really helps your partners provide care, if you're not there. If they have to read your note and carry on your plan of care, but can't read one stitch, or you left half of the encounter out, we see that a lot. So hopefully we can be kind to our colleagues and finish your notes and comprehensive. So common issues we're seeing is incorrect coding, upcoding, and unbundling. Where unbundling means we're billing three codes when the 2 codes is all you could bill. We are seeing not only an increase in coding denials or denials from insurance companies for diagnosis and CPT codes, but we're also seeing them increase in other areas. One being pre-authorization. And I'll go through coding best practices, but I wanted to make sure that you knew, I don't have this on the slide, that United Healthcare is under fire from our providers for increasing the pre-authorization for colonoscopies. They increase the pre-authorization requirements, and we already have set regulations across the nation, for depending on if they had pull-ups or not. So they're under big scrutiny for that as we speak. And also on May 26th, Cigna will start requiring a medical record for any E&M with a 25 modifier and a procedure completed in the same day, which is an administrative nightmare, an absolute outrage. And the AMA and all the associations have really gotten letters out to Cigna to stop this. Anthem, Blue Cross, and United tried this 3 years ago on the East Coast and were completely inundated by providers' voices to, stop that mandate and that administrative burden. And quite honestly, they said, quit practicing medicine. But, it is coming. Feel free, at the end of my presentation is my information. If you want the letter to send to Cigna to help stop this, because it will affect every provider, everyone across the country. They're doing it country and nationwide if we have a small procedure. So sorry to wean that off, but I didn't put that in, and I wanted to make sure that you were aware of it. And our voices do matter, and we have fixed it and stopped it. And so please, reach out to your payers. They are listening. Okay, coding best practices. On your services, make sure they're reasonable and necessary. The patient type, the setting, place of service, the level of service, make sure all of that is correct. On your plan of care, you need to document clearly, avoid brief generalization comments and care. must be representing the problem the physician is managing personally. How many of you are familiar with, the testing for appropriate use? Most of the pathology lab and imaging were required to have an appropriate use from our primary care or our orthopedic to see the patient for the MRI. That will be coming. They have not mandated it, but they said they're going to mandate it next year. So that means that we do have to go through an appropriate use questionnaire, and it is linked into our EMRs where we can, check the boxes and make sure. So when you send the referral over to, the imaging center or the radiology group, your appropriate use is there and done. They have not implemented that, and we hear it's coming next year, that we're supposed to be practicing, and not many providers know.
When someone comes in for a well adult check and they're being billed Medicare well adult check, and and then they have 101, they have their list of 101 things, so they only come in once a year. And we document that, because I can't not document that. What do we do? I mean, they deny it, right? And doesn't it invalidate their physical, or are you just basically doing free medicine by addressing our 101 problems? Because you're doing a well adult check while they're there.
Well, the well adult check with the notes of 101 problems, and when you show the payer the note, you're saying that they're denying it?
Yeah, they will pay this well adult check, that's it. And
So, Grace, are you talking about the annual wellness
Yeah.
exam that all Medicare beneficiaries are
Yeah.
entitled to? So we all, Medicare beneficiaries get an annual wellness exam, which is basically a preventative health visit, but they also come in with all their other complaints. But we can only get reimbursed for the annual wellness visit if we bill for that.
So the trick here is your ICD-10, okay? So your ICD-10 is for the wellness visit, right? You're checking the wellness. Don't put your 50 other ICD-10s on that explain all the others. Put it in your note. But again, one of my solutions is to actually have a coding audit every year so that we're compliant. And that was one of them, is make sure you do an annual. So Medicare recommends an annual coding audit. I recommend every quarter. Now, our billing and coding should be interfacing with you constantly about your coding habits, but it's just like a pediatrician. They'll put that you have strep throat, and then they'll also put an ICD-10 that a runny nose, and the payers are kicking it. Well, you're not supposed to have a runny nose ICD-10 with, a strep throat ICD-10 code. So really study your 10 codes, because that's the issue.
It's frustrating because, like I said, they're making rules on not how real practice is. Real practice is your patients come in once a year with their laundry list, and you're basically doing, you're supposed to just do this. And I have patients come in and says, don't document anything that's wrong with me, because then they won't pay it for me. And it's like, I can't not document that we talked about this. It's just, your hands are tied.
Well, are you doing your wellness and then your smoking cessation code and then your psychological valuation code? And
Physical is, it goes through all their problems, but I guess it changes the way we practice to not do that. I mean, for 40 years, I've had patients come in, my once a year, I'm getting all my stuff taken care of this year. I want this froze off, that froze off, this and everything on one visit, because they come in once a year. And but now I'm telling them I can't freeze those off. I've frozen off for the last 35 years, but now I can't, because the insurance will, they won't pay for it. And then it makes me sound like all I want is money. It just invalidates their well adult check. It just doesn't make sense that whoever makes the rules they're not on the front lines knowing how real medicine is.
well, I think, have you had a coding audit person help you? Okay. Because I think there is some workarounds on that, and actually, they want you to bill everything that you're doing. So if you're doing smoking cessation education with their well visit and your, you know, because I've seen primary care get some significant reimbursement because they've actually coded everything they've done with the well visit.
I'm gonna stick up for Grace here. So the annual wellness exam does include a lot of those codes that you're talking about, even CPT2 codes, you know, for depression screening and smoking cessation and all that. But the patient will also come in with their chronic conditions at that annual wellness visit, their diabetes or hypertension, and we cannot bill for both of those at that visit. So for me, it boils down to I have to figure out which is gonna reimburse better, the annual wellness fee that I get, or, you know, charging the EM code for taking care of their chronic conditions.
And
But you
and
end
the
up doing all of that in your slot, in your time slot.
in their
Sorry,
procedure.
but as an outside observer, can I just ask, why don't you tell the patient to come back?
Because people don't come back, they're, you know, they don't like
That's
them
their
to,
problem.
yeah, I know,
Right,
but,
it's unfair to you as a provider to try and have to take that on. I know
I
my
know,
office,
but-
Military,
we
when
pass
they
out
get a
a
laundry
sheet that
list thing,
says,
we say
this
we'll
is
cover
a
one or
preventative
two.
exam.
I
This
know.
is
And come
what's
back.
included.
when we
You
love
talk
our
about everything
patients,
else.
rural people, it's hard for them to get in there, you know, I mean, I know, and
Applying the
and I
real
have
world
a-
standards is not hating
I-
the patient.
I know, but it is, it's just, it's not the way we've done it in the past, and they've made new rules that make it so now it's
Yeah,
different. And like
I-
said, it's the same thing with the
Yeah.
colonoscopy, you get a screening colonoscopy, they pop off a polyp, and then all of a sudden it's a diagnostic, and then they're stuck with a big fat bill. I mean, we can't predict, you know, that that's gonna be a screening, and they're gonna find something in that colonoscopy, and then they come in with a bill and complain about the bill. I said, I'm sorry, I don't know who makes the rules.
I know, managed care has made our lives miserable, and in fact, as Cigna in the first quarter has a profit of 1.2 billion.
Yeah, and for them to say that you have to document the same day,
Exactly.
you know, they understand they got, you know, that you work
Exactly.
till, you know, 11:45, and that you don't have time, you know, sometimes to do your stuff. I mean, I think, you know, the people that are in the front lines, they're so busy, you know, doing medicine and doing what they need to do, that they can't go and lobby in Washington to get these things changed. You know, it's the primary care that's in the front lines that, I don't know, it's frustrating.
I agree.
The point is that it's a denial of service. It's just a way to whittle it down.
Well, think of it this way, if you share some of the pain with the patient, that'll motivate them to become politically active. Because they're getting their cake and eating it too, and you're getting all the pain. I mean, the patient should understand the onerous consequences of the system that we have.
Right, then you end up, and then they complain, and then you have to.
That's part of delivery.
I don't know. I just-
Well, it is hard, and you know,
It just changes the way you practice medicine and makes it, you know.
and when you go to the rural areas, they do. I mean, you know, they got off the, you know, they got off the tractor to come in. We can barely get guys to, you know, go to the doctor anyway, and they want it all done. And you know, I agree with you. Exactly. Yeah. And you know, a lot of people, it's hard to explain the healthcare, you know, the managed care, you know, idiosyncrasies, and you can't do this and I can't do that. And each one of them's different. Most of us here in Utah, we have 18 contracted payers, and they have at least 3 different plans, and each plan has a different rule. And it just becomes, I mean, how could anybody even comprehend all of that, right? But I think we do have to educate them. You want right for price. Well, let me just tell you, you also have restrictions. And I agree with you. You have to, I mean, I have to make a list for my derm, you know, Cigna only pays 4, you know, Blue Cross only pays 6, you know, so that they have that, so they can discuss it with the patient. Because until we get the LCDs linked into our system from the payers of all these idiosyncrasies, we can't communicate effectively to the patient because we don't know all of the problems and things that they do and don't cover. Um, so maybe we have to tell them on the annual wellness prior to their visit, we will just be, covering these things. If you have any others, I can make you an appointment shortly thereafter. Now, the next day, right? Can't do it the same day. Right. A human resource, we have a couple of discrimination, of course, can occur based on age, race, gender, religion, disabilities, etc. We've also seen harassment can be verbal, physical, and include sexual harassment. Um, there are 3 laws out there that help govern HR issues: Title V, Civil Rights, American Disability Act, and the Age Discrimination. What time is it? I've got 2 minutes. Okay, I'm going to speed through. So I'm not going to read those laws. There are an increase. We have seen an increase, and I think it's a movement from our younger generation, that they want to be treated, more equitable. But we are seeing an increase in discrimination issues. I've, put those there. Discrimination at workforce has increased 5%. Retaliation being the top one. Harassment has increased 2%. And the first 2 are offensive jokes and slurs. That's what we're seeing out there coming at employers. There is a new law, a Pump for Nursing Mothers Act, that was effective December 29th, 2022. National. Yep, national. And then, so that requires the employer to set aside a temporary or permanent private place where the mothers, your employees can go and pump. And they have time to, they get the time to breastfeed when they need to. The next one that's coming, Pregnant Workers Fairness Act, and that will be in effect June 27th, 2023. And that falls to make reasonable accommodations for your employees affected by pregnancy and child birth, denying employment opportunities based on the need for making such accommodations, requiring employees to take leave when accommodations can't be made, and taking adverse actions. So that is coming to us effective the 27th. So I put some policies and procedures here that will help. And that means that most of our HR policies need to be updated. Okay. So our financial policies need to be updated with the new ABN and the new No Surprise Care Act. Our HR policies need to be updated with these new 2 laws and how we're going to do that. One thing that we're seeing big in the industry is cyber attacks and cybersecurity issues. Okay. We have seen an increase. I have 5 practices that we have, been breached, compromised, and it's been horrific. It's very costly. So please be mindful of your cybersecurity, maintain encryption, make sure that you work with your employees and train them on privacy and security. It is a group effort. And make sure you do your risk assessments. The first thing the OIG asks for is your risk assessment. And what is that? That is a report that we go through and do we have more, this done? Have we had our firewall updated? There's a whole bunch. If you don't have that, you don't know what it is, then you need that. But that's the first thing the OIG asked for is your risk assessment. So it is a growing problem. 42% during the pandemic, we saw it rise. Over 600 breaches in the healthcare since 2021. 60 of those had ransom attacks. And the one that I had to deal with did have a ransom attack. And 4 years worth of billing data and patient charts were completely annihilated, completely deleted. We did find providers' information on the dark web out there, their social security numbers and all that. So it is massive. They predict that it's 22.6 total patients affected in 2021. So that's huge. And it is costing us millions, millions. Here's the areas: internal attacks, hacker attacks. So these are the areas that we're seeing most of the attacks on. And just, the biggest things: disclosure of PHI, breach of payment credit card data. We're seeing a lot of that. Infringement of personal data, and then lack of disaster preparedness. We've had systems go down. We don't have the schedule for tomorrow printed out or the day after. And so the clinics are really struggling. So solutions: complete a risk assessment and maintain it. Increase awareness within your office and make sure you train. Improve third-party security. So you get your IT people in there, have them go through your firewalls. And the last one that's really made a big difference is the multi-factor authentication. That has deterred 90%. Also, with your compliance manuals, I've given you a list here of all the criterias that should be in your compliance manual. That covers most of the comprehensive areas that you'll need. Reducing malpractice issues, accurate and complete documentation, effective communication. When I'm working with a doctor on their malpractice case and the malpractice carrier, many times we see the patient just didn't get enough communication with the provider. And they wanted that. Informed consents, make sure you get those signed. Those protect you. Follow up on referrals, and then quality assurance, and of course, comply with your laws. The anti-kickback laws, we won't go through the statutes because I know we're short on time. But the new law that came out, let's go back here. So anti-kickback arrangements, if we think about investments, physicians, it's like, oh, what can I invest in? You've told me everything I can't. But there are several, property, leasing companies. You can own a leasing company. You can own ASCs. You can own your clinic. So there's a lot of different arrangements and different investments that you can have. Just make sure you ask yourself these questions. But there is quite a few that you still have available to you. So there was 3 new safe harbors that came out for compensation: the value-based enterprise arrangement, the patient engagement and support, and the care coordination arrangement. Some of these were really beneficial for our clinics and our hospitals trying to work collaborative. It also, opened up a little bit of a mess between payers, hospitals, and other providers. But from what we have experienced so far, it really did help us align better with coordination of care. Well, the sprint regulations are all on there. This one was really helpful This will be the last one, but this was very helpful to help us with multi-specialty when we have to deal with DHS. It allowed us to put providers in pods, up to 5 each, when we were developing the comp models, and how with multi-specialty we have primary care and then we have orthopedics and and all that, and it really helped the comp model, which was awesome. So that was a good win on the sprint regulation.
We're gonna thank Jackie. It sounds like we could keep going a little bit on what's happening. Any pressing questions for our expert before we adjourn for today?
Excuse me?
Do you have a handout?
Yeah, I think
Sorry, if you could repeat the questions just for the people on Zoom.
he's asking if I have a handout. I do believe that the presentation, this presentation will be available for you. Yeah, I do have a brochure back there if you have additional questions. Pardon?
We'll check, but I believe it's on the application, the eMobi app. If you go into her time slot and click on her, then it'll have an attachment with her slide deck, I believe.
Yeah. And if you want to, I do have some brochures back there. If you want to take one of those, I'll be happy